There it is, the stroke of 12 o'clock. We started just like my old broadcast days. You know, you want to start the network show on time, and we just did that. Hello, and welcome to the webinar. It is great to see those of you who are online with us. I know more are coming, and I can understand the eagerness and the excitement for today's program. We have three great presentations and three great presenters, and each one is going to show you some different ways that you can provide better outcomes for your patients and actually increase your practice revenue. My name is Robert John Hughes. I'm the Chief Strategy Officer at Changewell Training Academy, where I get to work with Dr. Mark Tager, who's one of our presenters today. And it's a great privilege for me to be able to serve as your host today. So let's run down what you're going to hear. First, Dr. Jeff Farah. Give us a wave, Jeff. Jeff is going to tell us how bioidentical hormone replacement can make your patients feel better about themselves, and that will make them feel better about you. And in presentation number 2, Dr. Mark Tager is going to teach you about a breakthrough device that stimulates the vagus nerve, the body's superhighway to good health. And then in presentation number 3, Chad Erickson is going to show you how digital marketing can help you bring these new options to new patients and existing patients and help you grow your practice revenue. And I can tell you that working with each of our speakers, these presentations are going to be quite detailed and in-depth. And that's one reason why you'll be receiving a replay link shortly after we conclude today's session. The replay is so that you can come back and watch it again if you like, or if you can't stay for the entire program, we won't leave you out. And you don't have to request the replay. It will come to you automatically. You just watch your email. Now, here's a couple of notes. You may note that this webinar maybe looks a little more like television than like the internet. And the reason is we are using an extremely high quality delivery platform. As you know, on the internet, quality comes at a cost, and the cost is bandwidth. So there's a couple of things that you can do to enjoy the quality that we're capable of delivering. The first thing is shut down any programs or services that use your internet connection, such as Facebook, Instagram, Twitter, Dropbox, YouTube. These services use up your internet connection and they compete for bandwidth. Now, if anyone at your location is using your internet connection to stream movies or music or TV, ask them if they wouldn't mind putting that on pause for the duration of our presentation today. And if none of that works and you get that dreaded twirling wheel of death, like things are trying to get connected, don't worry. Our platform is monitoring your reception and will do everything it can to make things right for you as quickly as possible. And if all that fails, we have a backup system called the replay link, which, as I said, you will get right after the internet, after the webinar is over. Okay. Speaking of connections, take a look at the chat bar on the right side of your screen. Let's go ahead and use that. If you can hear me and see me okay, type in yes or okay. Let's see a few comments from people. How's the reception today? I've got this going on another computer. Okay, Mark says you can see me okay. There's Carla. I'm seeing Elaine and Tiffany and Barbara. Yes, Barbara, you are registered. Glad you made it. Tom, yes. Sean, yes. Okay, great. That's perfect. That's what I want to know. So let's find out what cities are represented. If you would, just go ahead and type in the location that you're at today. Let's see how global our reach has been. Chad's in Park City, Utah. Mark and I are in San Diego. Jeff, you're in Florida, right?
I'm in Tallahassee, yep.
Tallahassee, Florida. Okay. What cities are you guys in? Go ahead and put that in the chat right now. Okay. Dr. Mauricio is in San Diego. Elaine is in Westport, Connecticut. I'm seeing Carla in Beverly Hills and Barbara in Greensboro, North Carolina.
Copenhagen.
Sean's in Atlanta, Georgia. And there we are. Melissa's in Copenhagen. So we're officially global. Raul is, where's Raul? In Houston, Texas. Okay, great. Okay, good. I'm glad we've got some good representation. So now you know this is live, okay? It's not pre-recorded. We're interactive with you, and that's the way it's going to go throughout today. As I mentioned, we have 3 presentations, and at the end of each, we're going to spend a few minutes answering your questions. And if you have a question during the session, don't hold it till the end. Just go ahead and type it in the chat. We will be monitoring the chat for your questions, and we'll try to collect them, condense them, and ask the questions that are most relevant to the presentation. So during the event, just type into the chat your question, okay? Experience tells us that when you're exposed to these kinds of presentations, a question that naturally arises is, wow, that seems really good. How can I get started on that? And that's why at the end of each section, we're going to answer that question with an offer that has been custom designed for you by each one of our sponsors. And speaking of our sponsors, our thanks to them for their patience and support. Pellecome, Gamification, and MyAdvice, you guys are great. So before we get started, I want to just say thank you to all of you who have put aside the time to come today. We want to deliver maximum value to you. So what I'm going to suggest is, and I'm going to do it old school with a yellow legal pad, take notes and write it maybe at the top of the pad, write a question like this. Could what I'm hearing actually help me deliver better results for patients and make more money for our practice? Okay. So let's dive in. I'm going to introduce the first presentation. You know, when Dr. Tager and I are working with our clients on messaging, one of the points that we make is that we need to understand clearly what it is we're selling. Now, here's what I mean. Whatever treatment or procedure they pay you for, I'm going to suggest that's not why they came to you. What they want is the result of that treatment. Think about a facelift. Who wants bandages, swelling, bruising, minor pain? Nobody wants those things. But what they want is they want what happens after all of that, which is the compliments where somebody says, wow, you look amazing. So no matter what kind of practice you're in, people come to you because they want to feel better. They want to experience themselves being healthier, stronger, more alive, more energized, maybe even younger feeling. And that is why so many practices are interested in Pellecome and bioidentical hormone replacement. It's repeatedly been shown that optimizing hormone levels just makes people feel better, and that can enhance your practice revenue. Joining us now to present the Pellecome system and how it works, please welcome Pellecome's National Training Director. He is a chiropractor, nurse practitioner, and entrepreneur. Let's say hello and good afternoon to Dr. Jeff Farah. Take it away, Jeff.
Thank you. Welcome, everybody. Yeah, like he said, my name is Jeffrey Farah, and I handle the training nationwide for Pellecome. Pellecome is an advanced hormone delivery system. So part of today's presentation is going to be showing you the cutting edge technology that we are using to deliver hormones, but then also to briefly touch on what hormones can do for your practice. So there will be sort of both sides of it. We'll have a session at the end for question and answer. So please, if you have technical questions, feel free to put those in there as you think of them as we go through the slides. If there are logistical questions, if there are training questions, if there are in-depth hormone, whatever it is, make sure you type those down in the chat menu so that we can come back to those and we'll curate those at the end in case there's more than one person who has the same question. Again, my name is Dr. Jeffrey Farah. And then Dr. Telecom is the originator, and he's not with us today, but he's the originator and developer of this Pellecome system. He's a practicing OBGYN, 30 plus years of practice, an amazing, amazing brain that I still use after doing this for multiple years. I still use him as a resource. And that I will kind of go off topic here for a half second. This is one of the things that makes Pellecome really different and really exceptional for practitioners who want to jump in, is you have this great support system. So Dr. Telecom, myself, other practitioners, we're always there to answer and help as doctors get into this side of business. What we're going to talk about today, though, I really want to emphasize that the reason I love hormone therapy and the reason I love Pellecome is just outcomes. We've all, to certain degrees, been in the health business, and sometimes it has the tendency to, you feel like we're just spinning this wheel. And so the great thing about hormone therapy is you can sort of stop that and get these amazing results really quickly. So let's talk about those hormones. And this is not a science class, but just to sort of refresh everybody and let them know what it is exactly we're talking about. We're talking about these hormones that are important to your patients. And why? Because they improve metabolic function, they improve health markers, and they improve sexual function. All these things that are important for lifestyle, they're important for long-term health, and that patients are honestly seeking. So we're going to be talking about things like thyroid, cortisol, insulin, and then the big ones that we're going to be talking about in terms of hormone replacement are your estrogen, your testosterone, and your progesterone. So the sex hormones. And how do we optimize these hormones to then treat imbalances and the both subjective and objective complaints and issues that we're seeing? I think a lot of times in medicine, I was struck pretty early on that my patients had like 10 minutes by this managed care that I used to work with. And you had to give me one complaint, and it was always like a lab question or something like that. We never really dove deep into these things for the patients, but there's a lot that the patients are looking for from us as physicians. And so hormones provide a great way to treat those. So these hormone imbalances that can happen, whether it be from things like age, stress, lack of sleep, the lifestyle that we're all exposing ourselves to, lack of exercise. Heck, even we're seeing these huge uptick in serious conditions that are happening due to the current environments. We're just not made to be isolated like this. We're seeing huge upticks in lack of exercise, terrible eating patterns, the wrong foods, environmental toxins. There's actually a great research article, I believe is by Martin et al., that looked at bottled water. And there were upwards over 24,000 chemicals in a typical sample of a bottled water. And they identified 16 key endocrine disruptors in just one bottle of water. Now, we're not talking about huge mass quantities, but those endocrine disruptors had the ability to offset receptors for estrogen, testosterone, progesterone up to 90%. This is huge. So what are the long-term effects of that we're seeing in our population? I notice I'm seeing this. And if you do hormones, I love that you're on this talk, because we can talk about how to really optimize the practice that you're already doing. But the question is, why am I 27 with a testosterone of 200? I see it. It's out there. It's not this myth. And a lot of times we maybe don't have a great answer, but we're starting to see that these endocrine disruptors, these toxins that are in our environment, are playing a big role. In addition to the lifestyle of 2022, is where we're pushing harder, working longer days, stress. Those all have an endocrine disruption. So what other symptoms did you guys see coming into your practice all day long that relate to hormones? I mean, these down here are simply, they're huge, right? These are the ones that we see every day: fatigue, weight gain, brain fog, low libido. These are ones that patients are complaining and coming to us and searching for answers on a daily basis. And a lot of times we maybe run a panel. We look at, the basic yearly panel, whether it be thyroid, we look at their A1C. Maybe we dive a little bit deeper and we pull up some inflammatory markers or some vitamin markers. But a lot of times we don't necessarily have an answer, right? We said, well, you need to start eating better and, you've put on some weight. But that is not what the patient really can follow. They're not what they need. That's not what they're looking for, let alone things like blood sugar dysregulation. This one is especially important to me. This is what I did my thesis coming out of nurse practitioner school on. And there's a whole breadth of information, wealth of information out there on the association between the dropping of testosterone and the rising of our A1C levels, or our insulin sensitivities are becoming worse and worse as our testosterone drops. Now, is it a chicken or the egg? It's not fully decided, but so much so that I include a hormone check as a standard panel for anybody with blood glucose dysregulation in my primary care side of practice. In addition, I mean, if you look at the bottom down there, I didn't label them further, but if you look down the bottom, loss of muscle mass, weight gain, of course, we know hot flashes, dryness, mood swings. Those are some of the similar, most common ones that we've all known about. But how many patients walk in your door complaining about brain fog? low libido, are we asking that? I have found that a lot of physicians aren't asking that question. And when I just open that door to a lot of patients, it may be uncomfortable at first, but then a whole host of information from them comes out. So these are ways that we can address these really common things that our patients are bringing in, and we a lot of times don't have answers for. And the answers we have tend to not be very effective, honestly. So let's start talking about those big three that we mentioned earlier. So estrogen. We all know that estrogen is a female hormone. It's actually a male hormone as well. I always find that sometimes physicians and patients definitely are always surprised to hear estrogen plays a role in a man's world, but it is primarily seen as a female sexual development and the menstrual cycle, right? So we've always seen that. We've also seen it primarily on the end of the menopause, perimenopausal state of symptoms, which is hot flashes, right? But what we don't sometimes, or patients definitely don't understand, is dryness, incontinence, depression. Depression, anxiety is how I really like to explain this to patients, is those cycles of happy 1 minute, sad 1 minute, happy 1 minute, sad 1 minute. So it's this real juxtaposition of these polarizing, and they feel like they're honestly, they think they're losing their mind. Bone loss, osteoporosis, number one cause of postmenopausal woman is a drop in estrogen. So we're not only seeing these subjective complaints, we're actually seeing large major medical problems that can be related to dropping hormones. Not only the increase in adipose tissue, increased resistance, insulin resistance, and diabetes and heart attacks. These are a lot of things that patients don't maybe know, that we don't explain to patients, however you want to term it. But a lot of times, if they come in speaking and looking for estrogen help, it's when hot flashes come up. Well, there's a lot of stuff going on prior to that. And I like to explain to patients, as our hormones start to drop, it's not that, it's okay, hits a firm wall, and then we have a problem, right? The optimization is coming down over time, and these symptoms are starting to increase, and it can be maddening sometimes for patients because they don't know what's going on. And a lot of times, we as physicians don't look at optimization. We just look at these hard cutoffs. So let's go down this further. Oops. There we go. Let's look at some more hormones. Progesterone. A lot of times we see this talked about, I think, in the pregnancy world. A lot of times it's not given much credence elsewhere, but there's a lot of important factors that come along with progesterone. Of course, we have the endometrial protection, right? We have the breast cancer, help with breast cancer due to the opposition of estrogen receptors. But there's some important things that subjectively also progesterone does. So we have a sedative effect from it, right? We have this mood stabilizing effect during PMS or menopausal symptoms. Irregular bleeding, right? These are things that a lot of times we're sending off to an OBGYN, and rightly so if we have serious issues that need to be dealt with. But if we have an understanding of these, then it bolsters that confidence from the patient. You also see this anxiety depression scale again. I think I explain it to a lot of times to patients like this is, for men, the primary hormone, testosterone, right? Is there a symptom and it's related to hormones? Your testosterone is low, right? We're a little simpler creature, but you see a lot of these same symptoms popping up on the female ones. Same symptoms for estrogen and progesterone, right? We have this anxiety, depression, because it's a very yin and yang thing, right? They have this correlation. An aspect of something might be controlled, the same broad topic, but controlled by different varying hormones, right? So I like to use libido and sex as an example for females, right? So a lot of times if I ask a female about her libido, she might say, yeah, I have low libido. If we dig and we dig and we dig, sometimes it's because it's painful during sex, right? So that may be an estrogen side. That may be the performance side. That may be the dryness side. Or she may just have low libido. That could be the testosterone side, right? So there's this interplay between the hormones. It's not always as simple as sometimes the males can be when you're looking at a surface level. So it's important to understand some of these subjective issues that come along with hormones so that we can effectively talk to our patients about what hormone replacement might look like and what it would involve based on the symptoms that they're having. And then, of course, testosterone. Looks like that slide's maybe a little bit small, so I apologize to you guys. But when you look at testosterone, what are the roles of testosterone again? So it's mainly thought of as a male hormone, but that's not true in the least. It's just as effective and important in females, maybe in varying degrees, right? So we have a smaller absolute value, but that doesn't make the importance any less. And so we have regulation of muscle mass. We have fat distribution. We have fat to muscle ratio. We have bone density, fertility, red blood cell production, right? And like I said, do women make testosterone? 100%. It's always a surprise. It's always a surprise to a female patient when you say, yeah, I'm going to check your hormones. We're going to look at your testosterone, your estrogen, your progesterone, right? Testosterone, why? You make testosterone. Your libido is controlled by your testosterone. Your muscle mass, your bone density is influenced by these things. Your mood is influenced by this. It's a smaller absolute number, but no less important. So I really encourage, if there's just one simple takeaway, start checking a full hormone panel in your patients if you check hormones. Nothing drives me crazier than a woman who comes in and says, oh, yeah, I was told by a doctor my hormones are fine, and I see an FSH value. Or I see just an estrogen value. Or maybe they're cutting edge and they did FSH and estrogen. I'm like, well, okay, we got two of them. That's some information. Let's talk about what that means. But let's do a full complement panel, right? Let's look at the whole picture before we decide whether or not there's an issue that warrants us treating. So I think this is important, is looking at where testosterone is made. And this is always intriguing to patients, is for females, it's made in your ovaries and your adrenal glands, right? And then you have this conversion in fat tissue, right? So as we females start to age, as those ovaries start to decline in their production, the adrenals will be the primary reliance source. And so you start to see this decline in testosterone production pretty significantly as the ovaries. And if there's any excess adrenal stress, and I don't mean that as an external stress, but like stressors where they're just not producing as well, also, you can get a significant drop in testosterone fairly quickly. So what does it look like when testosterone drops in a patient, whether it is man or woman, right? Brain fog is a real common one. Low sex drive, low libido. In depression is kind of the term we use, but I always tell patients, and men are pretty classic in their description of this. They'll say, doc, no, I'm not depressed, right? And I don't know if that's a male thing. They don't want to be identified with that, or if it really almost isn't, though. It's like, no, I'm not depressed. I'm not clinically, I'm not sad. I kind of just don't care anymore. And they almost pause and they have a hard time articulating that, but it's pretty darn specific. If you start listening, and it's a loss of volition. It's a loss of drive. It's a loss of the ability to sometimes establish and get pleasure from the things that you used to, right? There's a big, strong correlation between our dopamine and our testosterone. And it's not so much that the testosterone gives us that sense of pleasure, but when you have these testosterone producing events, the body in a man especially really from a physiological standpoint likes that. And so it gives you that hit of dopamine and it rewards you for that, right? So we're in North Florida, South Georgia region. So I use examples right outside. We have a lot of hunters. We have a lot of fishers. I have a lot of athletic people. Part of my practice, I own a gym. So I see a lot of these type of population. And there's a rush you get from a hard workout. There's something that is established in you when you get a little testosterone bump in your body, and your body gives you that hit of dopamine. It says, yes, we like that. That produces favorable results in us physiologically. But as your testosterone drops, you stop getting those little physiological things that happen. So therefore you stop getting that dopamine hit. And it produces this loss of like, ho-hums. My daughter, my middle one, she used to call it the molly grubs. And I think that was just a great example. I think it was a Care Bears thing. But, you know, it just, the word just kind of, you're like, yeah, I just kind of don't like it a lot, right? And then that can lead to fatigue, right? If we stop exercising, if we stop doing the things we like, we stop caring as much, we start sitting on the couch more, and that breeds more and more of that sort of fatigue mindset, right? We stop exercising, we stop losing the energy, that production that we needed. So That's really, really important. I really want to stress to the attendees, testosterone, check it in your females and your males, and younger populations. It's almost epidemic levels in men. I am shocked every day. I'm seeing men in their 20s, testosterones of 200s, and that's significantly low. And so, again, are women tested for are women treated for testosterone? Yes, 100%. This has been around for a long time, since the 40s. I've got a 60-year-old patient. His in-laws used to go up to Atlanta and get pellets. So you can imagine there's a long proven record of these pellet therapies. So let's look at some of this hormone replacement recommendations. Let's talk about the women first. So there was this initial recommendations after the World Health Initiative, right? In the late 90s, early, I want to say 98, 2000, 2004, they did these series of studies and culminated this data from the World Health Initiative. And if you were trained in primary care like I was, it was like, oh my God, don't do any of this stuff, right? Use the lowest dose possible. Use the shortest time you can to treat symptoms. Stop it at 65 because we thought it would worsen these dementia symptoms, right? Now, that dementia one, there was a great study. I can get my desk. I'm sure like yours is full of studies. I won't pull it out. But there's a great study that showed the lifetime of exposure to estrogen, the longer, the more gray matter there was in brain. So there couldn't be anything more further from the truth, right? So we're starting to see these new hormone replacement guidelines come out, right? So the greatest benefit, yes, is seen in women under 60. And it's really important that you initiate treatment prior to we hit this 10-year mark post-menopause. And so I always tell doctors, we need to check these hormones when women are young and they're ideally at a normal level, right? So we can catch these dips sooner and sooner. And there's no reason to stop your hormone treatment when a woman hits 65 because there is a lot of long-term health benefits that come from estrogen as well as testosterone exposure, not just the subjective things. We're talking about dementia. There's going to be a wave of this dementia that's coming as the baby boomers get older and older, and as the generation behind them starts to be better and better at our saving our lives, and we're living longer, but we're going to start now dealing with the repercussions of that long life. So things that you can do to prevent dementia, for sure, are practice builders. Things that you can do to prevent hip fractures, increase muscle mass, getting out of hospital sooner. These are all great things that we need to start thinking about for our patients. So let's talk about the female optimal candidate. Like, who's walking in your door? Who in your practice? Who do you know that needs this, right? So the pre-menopausal, right? We're starting to see this in the mid to late 40s, but I would actually say that's starting to back up. I'm starting to see it in the early 40s, even late 30s, early signs of it, right? Now, those aren't always common, but you start to see fatigue, stress, weight gain, and they've been in a career for a while. So these aren't new things, right? They don't have a new young child at home, right? These are things that are coming on as their hormones start to decrease. And then you start dipping into that perimenopausal, right? So we get some hormonal irregularities. Our ovaries stop producing, as we're not on the clock 28 days. We see some irregular bleeding. We see some brain fog, insomnia, huge practice. If you start asking your patients about insomnia, I always joke that sleep is the currency of adulthood. If you can give people better sleep, they will love you forever. And then, of course, menopausal symptoms, right? These women are all perfect candidates. That's the one that every woman knows. And they're saying they're having hot flashes. They're saying they're having these significant, they know, they talk to their mom, they talk to their aunts, they've talked to their friends. A lot of times in the early stages, women aren't really understanding that fatigue and stress and weight gain and brain fog and anxiety are related to hormone dips. And so it's important that we start having these conversations. And again, don't be afraid to talk to your female patients about libido. That's a big one. It's important to females as much as it is males. There's a strong misnomer that it's a male symptom that's important. It's important for both sexes. It's important for relationships. It's more than just a physical act, right? It's an intimacy. It's a part of a marriage. And I find that relationships are deeply affected by hormone treatments as well. So let's briefly go into recommendations for men. Like I said, it's this big, it's a big issue. It's bigger than I think a lot of docs. It's no longer relegated to this back alley, what I call bro science, where, you know, people in the gym do testosterone and It is not that anymore. It is a major medical condition that's affecting younger and younger populations. We're seeing younger or lower and lower sperm counts. We're seeing lower and lower testosterone values. I'll give you a little tip that I see in my practice. The three biggest areas that I see younger men that have significantly low testosterone. I see military, I see firefighters, and I see police. And it was weird because I just kept seeing the same subset of patients. And I run a concierge practice, so it's a smaller terms of patient volume. So I end up talking to my clients a lot. We talk about what they do, their life, kids, family, yada, yada, jobs. And I would see these young guys that started in the force or the military at 17 or 18, right? And I would see these then going off to maybe combat or maybe this low grade PTSD that comes from being in the police force or doing homicide, or as the new guy on the force or the new guy at the station, if it's fire, you get pretty crappy shifts, right? What's that mean? Late nights. So your sleep regulation is way off, right? You're working nights for 5, 6, 7, 8 years. Now you wake up and you're 28 and you've been doing this for 10 plus years, and it makes a significant toll. So those are the three biggest male populations I see with a really young patient base. But again, just because they're young or old, there's no reason to deny testosterone. It's not just a young man's. It's not just a 40-year-old's hormone. There is no medical basis to deny testosterone replacement. I have cancer patients who are using it to bolster themselves out of chemo, right? We talked to their oncologist. Oncologist is on board. I had a patient just this week, pancreatic tumor, chemo, massive surgery, comes out of it, and they look like a shell of a person. You just feel for them. We did some testosterone pellets, got the okay from his oncologist, boom. And in a really short amount of time, he came back in. I'm like, my God, you look like a new man. He's like, I feel great. I put on some muscle. I got my appetite back. His bowel movements actually started regulating themselves. Doc is on board with it. Oncologist is impressed. So now these are extreme cases sometimes that maybe are outliers, but are important to understand that this is not something that we are just looking for a specific patient base. It's effective. There is plenty and more research that's coming out on its effectiveness, its safety. There was a strong risk aversion I saw in primary care is due to two things: cardiovascular concerns and then prostate concerns. And so would you actually look at the research on this, though, guys, there really is no evidence to support an increase in no increased risk in cardiovascular health, right? And there is no risk in prostate cancer. Those studies from way back were really poor. They got kind of steeped in literature, and we're seeing now that potentially some of the newer research is showing that it's a potential dip in testosterone and a rise in estrogen in a man that makes this really ripe environment that can be upregulating of prostate cancer. That's still to be seen, but it's pretty interesting data. So don't think of it as just a 40 or 50-year-old, right? Either end of the spectrum, there's no real rationale for denying care on either side. So who are these optimal candidates, right? So it's kind of important to understand as we hit 30 and beyond, we should see a nice, slow, steady, normal decline, right? This is natural. You're not going to have the testosterone at 80 that you are at 18, right? That is a normal physiological process. However, you should not have the testosterone at 30 that you would expect in an 80-year-old. And so I pulled one of my primary care patients the other day, pulled his yearly labs. I checked testosterone, 61, testosterone 750. I'm like, go, brother, you're killing it, man. Like my other patient base would love to have your testosterone. So sometimes we feel like, everyone's saying that everyone has low testosterone. Everyone has low testosterone. It's not true. There are 60-year-olds that have a great metabolic health. And when you see those, it reminds you how bad that 35-year-old who has a testosterone of 290 or 320 even though it might be in the LabCorp regular scale of 260 to 960 or whatever they're saying these days in your region. But you shouldn't see these big, huge plateaus, right? 1.5% yearly. And you start to see a man complain about loss of energy, loss of muscle mass, again, depression, anxiety, the low libido, right? That's a big one, a big telltale sign for males, is that low libido. Again, so who are maybe more specifically optimal candidates for pellet therapy now? So this is specific to pellet therapy. I love pellet therapy. It has been a game changer in my practice. So I see this a lot, is suboptimal results with hormone therapy previously, right? They were doing creams, patches, orals, whatever it may have been. Nasal spray for men, right? Oh, I was told to do this nasal spray 4 times a day. I was told to put a cream on a few times a day, and I couldn't ever remember. Absorptions were all over the board. And what you get is these big fluctuating. So I don't know if my mouse shows up on this screen. It does on mine, but what you're looking for is this pellet therapy. As it reaches this steady level, is you get this 3 to 4 month, 5 month, nice steady delivery, right? Versus you see these orals and creams, you get these big peaks and valleys. Patches tend to rise and wane really quickly. Injections are notorious. I would even say that this, while a representation, not actual data, it's much steeper than this orange one, this injection. It's almost a V, an upside down V, right? You get this big spike and a big drop. So a lot of these things lead to just poor results. They say, hormones didn't work for me. Not true necessarily. And then you just get non-compliance, right? Compliance is already tough for every patient and doctor relationship. And so the other thing is you can really seek customized titrations, right? The injections come in a standard dose. It's hard to do sometimes when you're trying to figure it out for patients, especially females. It's a no-go for females. It's just too difficult. But even for men, it's hard. You have to titrate to these really small doses. Pellets, you get the pellet customized made for them. Boom, they do these great results, and compliance is great. And the patient's happy, right? There's nothing better than a patient coming into you for an appointment and they're excited to see you, right? They leave with a smile on their face. They pay cash gladly, right? My standard joke, if you want to even call it that, I tell patients, and I don't really think of it as a joke, is I tell my patients, if I came in the room on your next pellet insertion and I told you, hey, I got bad news, Joe, pellets doubled in price, right? Corona, supply chain issues, right? The price just doubled. And if you bat an eye, then I start to wonder if this is really even working for you. They're paying out of pocket $600, $700, $800, $900, $1,000 in some markets. They would gladly pay double. Trust me, they will do it. And they laugh and they say, well, I don't know about that. But honestly, the results are that good that they definitely would. And that's what I think is great. Patients are happy to see you. We don't get that a lot in this practice, right? It can sometimes beat you down. But to have a patient happy to see you, happy to come back, happy to pay, no insurance to fight, then that's a win-win across the board for everybody. So let's briefly go into what these pellets are. Like, what exactly even are pellets? You've been hearing this word from patients, or, this is a pellet presentation. So these are bioidentical pellets that are in pharmacies compressed into little cylinders. You can see up in this top corner underneath my picture in that little blister pack. I always tell patients they look like a Tic Tac. Grain of rice is what I've heard. Those appear to be male pellets. They're a little bit bigger, so the Tic Tac, not necessarily a grain of rice. And they contain estrogen, progesterone, testosterone. We even have weight loss pellets now, which are pretty exciting. And you insert them into the subcutaneous tissue, right? So you make a small insertion in office, just local anesthetic. I teach this. This is the main role I do in Pellecome. I teach doctors how to do the inserts, as well as some of the educational side of things. And I teach you how to do it in office, right? I teach primary cares. I teach nurse practitioners. I teach non-surgeons all the time. This is not something you have to be skilled as a surgeon. In fact, I find that maybe sometimes my surgeons are the harder ones to treat, right? They already know how to do procedures. And so, but you dose the patient specific to them, right? You do a little calculation and you find out what they need. And what is the beauty of a pellet? Why is a pellet even better, right? So it's nice, consistent delivery, no issue with compliance. It's inserted in the subcutaneous tissue. They don't feel it. That's another misconception. You don't feel like a little lump where it's placed. You don't feel a bump. You don't know it's there. It's not an implant like I don't know, like a spinal implant or something where you have to wear something external. It's placed under the skin. You don't know it's there. You go back to your normal everyday life. Again, I work in my practice is actually in a gym that I own, right? It's a dual medical health fitness center. And so a lot of my patients obviously come from that world and they go back to working out. Nobody knows that they're not doing something different. They're not avoiding anything. They do everything they want to do. We're in Florida, a lot of boating, a lot of water activities. So, but it's important to understand that it bypasses that first pass metabolism, right? So it's bypassing that enteral hepatic circulation. So we don't have to we don't see those elevations, those potential elevations that we would see maybe with injections with liver enzymes. Much better compliance, much better effectiveness. And the great thing is they're done for 3 or 4, sometimes 4+ months, right? So you don't have to come in the office. You don't have to do like I have some clinics here that run weekly injections where the guys come down and get their injection, or you're mailed a bunch of syringes or something silly like that. They just come in your office. Boom. I can get a patient. I'm long-winded with my patients. Again, I run a concierge practice. I know them. We're friends to a certain degree. But if you're in a rush, I can get you in and out of the office, door to door, checked out in 10 minutes. It's not a huge procedure, and I don't even use an assistant. So if you're worried about, it's going to take a long time, I'm not going to have time for my other patients, yada, yada. No, it fits into a practice really well. There's an insertion visit, right? It's not the same one that you would do and sit and talk symptoms. You have already done all that work. And so they're in and out the door really quick, especially if you have assistants. Again, how are they? We're not going to talk too much about this, but how are they absorbed? This is good information that I want you guys to have. If you go back and you're like, I wanted to learn about what these pellets are. I have my patients asking me all the time. I wanted to be able to educate them on what these guys are, right? So the testosterones are made, pellets are made from wild yams. They have a identical chemical structure. And they're sort of bound together, compressed with this cholesterol. And so there's different ways that they can be formed, and they have a uniform erosion or uniform distribution that happens. That's due to the surface area of the pellet. So a lot of patients will ask you, one of the things is, well, give me more pellets and I'll go longer and I'll have to see you for 6 months. It doesn't necessarily work that. It's the amount of surface area. So more pellets, you have more surface area, you just go higher and you get the same amount of disillusionment. So go back and look at the slide if you're really interested in what pellets are and specifically how they're made in the pharmacies and those kind of things. But that's what this slide's about. I want to go in and show you guys a presentation. So I wanted to talk about this, though, is quickly, how do I do my hormone pellets for women, right? So we do pre-insertion labs. We screen this person. We do pre-insertion labs. You then identified the candidate, right? Pellecome makes it great in that we have a lot of this information already in a sort of plug and play. Like, what labs do I need? We got that information for you. Well, how do I figure out what dose? I'm new to pellets. I'm new to hormones. This is overwhelming, right? I teach newbies this all the time. We have this amazing thing called the Pellet doser. Dr. Telecom, I'm not even privy to this algorithm, right? It's top secret for Dr. Telecom, that 30+ years of experience as an OBGYN. The Pellet doser, it gives you great clinical guidelines. It screens for potential contraindications, right? A bright red thing comes up and says, did you miss this symptom? Maybe we want to consider this wasn't great for this patient, right? Gives you some guidelines of where to work with a starting dose. And then we always do follow-up labs. We're checking for issues. We're checking for the unknown. We're looking for patient safety, right? These are the most important patient safeties. And then you follow up. You have a scheduled follow-up in 3 to 4 months. And the patients never miss those appointments. Trust me. Same thing for men. Pre-insertion, hormone is testosterone. The women is testosterone, progesterone, estrogen, if needed, depending on what they need. Our goal is to maintain testosterone in the higher upper limits, over 600. And then you're going to reevaluate, pushing out to, again, you don't need to do labs every 6 weeks. You're going to push out to eventually once a year, once we manage and set their dose. And the great thing about Pellecome is we're going to teach you how to deal with these things that may come up in terms of elevated estrogen post testosterone. Do we have any rising hemoglobin hematocrit? Do we have an elevated PSA? what do we need to do with that, right? We train you on all of this thing, and we have a strong clinical team behind to answer questions for all of our licensees. Here is the Pellecome system. How are we doing on time, guys? Is there a good time to show that video of what we're looking at of an insertion? I don't want to miss that.
Yeah, go ahead.
Yeah, so this is the device. We'll come back to this, but I want to show you what an actual insertion looks like. So, all right, so first step is we're going to open the procedural kit that we talked about. It has everything that you're going to need for the insertion, except for sterile gloves. So you're going to want to have your own sterile gloves in your size. We're going to open this in sterile fashion, just like you would in any other condition. Now, I do my procedure without an assistant, so I'm not gloved up. And so what I'll do is I'll come in here and grab this sterile tray. And you're going to see there is a syringe and needles in there. So I just let them come off to the side. And then I'll use this tray. And again, if you have an assistant, obviously a much different. I just prefer to actually do them without my assistant. So, but you still don't want to break sterility. All right, once you have your pink 18 gauge draw needle on there, you're going to have your anesthetic handy. Again, if you have an assistant, this can be drawn up prior to. Comes with a 20 ml syringe, so you got plenty of room. I'm going to start with 5 cc's of my lidocaine with epi. Again, it's not an absolute necessity, but that epinephrine will help stop any bleeding. And you don't need a lot, and I always ask my patients if they're getting any jitters from it, because you want to be aware of that. Next, we're going to do 5 cc's of Marcaine, long-acting anesthetic. And then a little bit of sodium bicarb as a buffer. Just helps with the acidity of that solution. And then it comes with a 2-inch needle on there, which is important because you want to make sure you get to the end of where that trocar is going in the skin. And then next, you're going to see here that I have got my tracks. On this individual, we're going to be doing 3 tracks, and you can only do 3 pellets per track. So don't ever try to put more extra in there. All right, so we're going to anesthetize the patient here. The first thing we're going to do, big stick coming, buddy, is we're going to start and we're going to make a little wheel here at the skin. And I don't know if you can appreciate that on video, but you're going to see that skin just bubble up just a little. Now you know that skin. From there, we're going to go deep at the insertion site. And then we're going to follow each of our tracks, feathering a little bit of anesthetic. And I will generally do a little right, a little left, but I don't ever take my needle out. You don't want to create more trauma centers. Good. And then from there, you're going to wait just a couple minutes. I like to give that anesthetic time. That keeps you from having to use a lot of anesthetic. At this point, though, I like to push all that fluid out. We don't want any edema in there. Good. So while he's numbing up, I'm going to go ahead and get my pellets and my tray ready. So again, I do this without an assistant. So you're going to take your device, comes in this. You want to make sure for a male, obviously you're using a man. Take those, dump them on the tray. You're going to want to have extra needles. 1 needle comes in the kit. He's doing 3 tracks, so we're going to need 2 additional needles. I keep a little extra, just 2% lidocaine on hand, just in case I get during the procedure and for whatever reason he needs a little extra numbing, so I keep that on hand. The next thing we're going to do is we're going to get our pellets. All right. One of the hardest parts of this procedure is opening these little blister packs. I prefer, and you can tell your assistant, do without gloves. You can also snip them if you have some sterile gloves. You just want to make sure you don't open it too quick and you pop them out. So I'll open them carefully and individually and drop them on my tray. There is a cup in there. If the assistant sets it up for you, you'll drop it in the cup. I have found this to be just as easy though, because I got a whole sterile field here. And while you're doing this, this kind of lets that anesthetic take effect, which you will find that you don't have to use quite as much anesthetic, which leads to less edema, a little less trauma, a smoother insertion overall in the long run. So sometimes we want to use extra 20, 30 cc's of anesthetic, and if you're not waiting a few 3 to 5 minutes, that can be necessary, but if you take just a little extra time, it works well. All right, once you're sterile gloved up, you're going to go ahead and load the trocars. You'll come if you're using one, it comes with this preloaded funnel that you will take off for the other ones. You're simply just going to grab your 200 milligram pellets and drop them in. There's no forcing, they just slide right in. 3 per trocar. Set that aside, don't tip it forward. Take your funnel off, place it on the next one, and you're just dropping them in. This funnel is great because it helps you. You're never going to drop one on the floor. If you've used that old trocar system, you know what I'm talking about. I like to load up all my pellets before I start the procedure as opposed to one trocar at a time. So now I'm ready to go. All 3 are loaded. You're going to take your device, right? Thumb against the slide. And this little notch, if you can appreciate it on video, and you'll see it in person when you use the device, this little notch is going to be at your 12 o'clock position. That's what allows the device to lock in there. You line it up and simply slide it on. Good. Now it's not forcing. If you push too hard on this, you'll drive that plastic cap into the trocar. It's on there. It's not going anywhere. If you want to check, you can, but don't push super hard. At this point, I know I'm ready to go. I want to make sure my patient is anesthetized. I'm going to do a final cleanse. Take your ChloraPrep. Just like you would any other, make your good concentric circles. I always go wider than necessary, just because you never know where your drape's going to line up. Comes with a fenestrated drape with adhesive. Keep it nice and folded as such. Pull off your adhesive. And you want to expose your insertion site right where you made that wheel. Press it on there nice and good. Drape it over the patient, and you've got a nice, good, sterile surgical site. From here, I always do a double check just to make sure they're anesthetized, and I'll give them a hard pinch. Feel anything? Yes. He doesn't feel anything. I'll double check because the last thing you want to do is make sure that you didn't anesthetize them. Here is the precision scalpel, right? This is pre-measured to the size of your trocar. So no more freehand scalpel incisions with an 11 blade, right? That just led to over making the wound even bigger than it needed to be. So this is pre-measured. I'll expose it just a little, come in here and give them just a poke, make sure we don't feel anything. Good. So then I'm going to take with my non-dominant hand, I'm going to pinch the skin up a little bit so I have good control. I like to expose that blade just a little so I line it up properly. I place it on, and I'm simply just going to insert it, right? It plungers. It's not a fast plunge. It's not a vicious plunge. It naturally does that for you. So now I've got my wound, or my incision site, I should say, open. Take my 4x4 in there. Expose my trocar. And we've got our 3 tracks that you can see I've defined that I'm going to go to. And that's just a good guide for me. I'm going to start with the trocar, and I just want to slowly work it in. I'm going to have it at this 9 o'clock position. Once I make that insertion, I rotate it to 12, and I'm going to finish my insertion till the safety hub touches the skin. Now I know my depth is good. I don't need to go any further. I've got consistent depth. I drop, and I'm going to aim at that wall on my first track, and it's just going to slide in. Good. Keeping pressure on this tab until you're almost hubbed. From there, you pull back all the way, and then slide your device out. Just like that. Now these male devices, like we talked about earlier, are different than the female devices. They don't lock because you're using one device but multiple needles. So you're going to slide it back forward, rotate it to 3 o'clock, and simply slide it off. Get your next one. Make sure your tab is at 12 o'clock. Line it up. You'll hear a little click, not too hard. Expose it, and you're ready to go. Again, you're going to just slide in the same insertion site, rotate back to 12, touches the skin with the safety. I lower my elbow, and I'm just sliding it in. I'm not using force. And then pull this back before I take the device out. And if you've ever used that old trocar system, you know, you can tell instantly this is a much different procedure, right? That old trocar with a diamond cutted blade, you had to sort of wedge it in there and you had to get force behind it to make that incision. This is not so. Again, you're going to push it out, rotate, take it off. Next one. Line that up at 12 o'clock, and you're good to go. Expose your op site. Insert it 9 o'clock. In, rotate to 12. Make contact with the skin. Drop your elbow, and just gently, consistently push the trocar in. Now right here we've hit just a hair bit of resistance, and that's okay. I don't wedge and I don't force, right? I just give it steady pressure, and you'll feel it. There it is. Not much pressure, right? The old system, you would bear down and start turning and forcing it in there. Do not do that with this new device. From there, pull all the way back. That deploys the pellets perfectly and evenly. From there, pressure. I like to hold pressure for 30 to 60 seconds after a male insertion to make sure I push out any edema, make sure there's no bleeding, and just give it good, constant pressure. This is the only time you put a little bit of force behind it, just a little bit of body weight. You want to see his hip just roll forward just a touch. And again, we're just putting a little bit of resistance in there. Good. Once you're done with that, I like to take off my drape, expose the op site, and we're going to make that wound closure. Now here's a big key. You have 2 4x4s in here. So this is not bleeding at all, as you can see. But what I like to do is take my new 4x4, give it one more 5-second pressure, and I should see nothing more than a spot of blood. Perfect. And I should see no active bleeding before I put my Steri Strips on. Your Steri Strips come in the kit. You're going to expose them. I do them with my forceps. So you're going to grab the far end. This is important for your wound closure. And now there's no blood. If you have any blood, you keep pressure until it stops bleeding. Otherwise, you'll get scarring in there. So you don't want any blood in between the 2 sides of the incision. Place it over, close it with your thumb, then lay the Steri Strip over. And again, you should see no blood coming out. If you do, stop and start over. This is the most important part for scarring. You've taken time, lay it over, close the wound, finish. You've taken time to use this new device, which limits scarring. It makes a smaller incision. Make sure you take an extra 30 seconds to do this properly. For my males, I will do what I call fence posts, 2 across the wound, horizontally, 2 across the wound, vertically. And that's it. You are good to go. I will take my alcohol, clean off a little bit of that marker that you use. If there are any drops of blood, just to make it look good. You don't want any blood underneath your op site. From there, you take one of your 2x2s. You're going to fold it in fourths. Comes with your prepackaged tegaderm. You're going to place your 4x4 in the center of the tegaderm, right over the op site, and then again pressure. A full 60 seconds at this point. You felt that more than anything, didn't you? That sticker coming off. All right, thanks, guys. Hope you enjoy.
If you're not currently offering BHRT in your practice, you might be thinking after seeing this presentation, why not? I mean, if you have patients coming in who are happy with the results and they're willing to pay cash and pay double if it's necessary, I mean, that's a good thing. But the focus really is on the results. So the logical next question would be, if this can provide such great results for my patients, how can I get started and why should I choose Pellecome? And here's some answers. It starts with the realization that you might think, if you've never done BHRT, and I haven't, I'm not a doctor even, that it could be difficult or intimidating. And it's true that there are some things to learn, as Jeff has shown us. And I think that's one of the reasons why Pellecome has a really distinct advantage. They offer the most comprehensive training program. Let's go ahead on your slides here. Here's a couple of options for the training. Option one, this begins with a 10-module didactic learning video session. And this is created by Dr. Telecom and by our own Dr. Mark Tager. Then part two is the live hands-on course. And there are multiple locations and dates. The next available are February 5th at Dr. Telecom's clinic in Rancho Mirage, or February 26th in Orlando, Florida. Cost for that is $1,950, but you won't pay that, and I'll explain why in just a minute. So option number two, this is virtual training. There's no traveling involved. It begins with the 10-module didactic learning program, and then you connect with Dr. Jeff online virtually, and you go through the training there. And the cost for that is $2,750, but you won't pay that, and I'll tell you why in just a minute. The reason why is because of this special offer. You might want to grab your phone and grab a picture of this. We'll send it to you in the follow-up email. You can get 22% off the training option 1 or 2 if you use the code WEB22. You have to register and pay by January 24th, and there is the link on the screen. Again, we will send this to you. So if you want to grab a picture of it, go ahead and do that. And like that. Once you complete your training, what happens next is the Pellecome team goes to work for you designing packages that are perfect for your patients and profitable for you. So I can imagine, if you're a practitioner, that adding something like this to your practice is an important decision. And Pellecome has proven to be a really valuable resource. Not only are you learning bioidentical hormone replacement therapy from the leaders in the industry, Dr. Telecom and Dr. Farah, but you're also using the one-of-a-kind patented pellet insertion device. Dr. Telecom actually invented this device with his over 30 years of surgical and pellet insertion experience. From the business perspective, the advantages of Pellecome: no procedure fees, there's no contracts, there's no autoclaving, just higher profits. And again, grab your camera and get a shot of this. And Jeff, let's go ahead and see if we can take some questions here. I noticed one from Albert, a comment really. He says the failure of the WH1 is that they use progestin, not progesterone. Do you want to comment on that?
Yeah, what he's talking about is in the World Health Initiative. The World Health Initiative study, you get a lot of polarization like we're seeing today. Like people are like, oh, this is a failed study. Oh, this is terrible. I don't think it's a failed study at all. It gave us a lot of insight. And what he's referring to there is the combination of progestins, the synthetic form of the hormones. There seemed to be a combination of that synthetic combination with the estrogens that caused an increased risk of breast cancer. So we're using the progesterone for this endometrial protection, or the progestins again in that study. And so what they're talking about is that using the progesterone would not have had that same effect using a bioidentical. So I think there was another comment that's just conjecture because there was no comparison arm of the study. Yes, and then that's where you start to see this diving in. The one thing that we did learn is that do not use that combination. There is an uptick in risk of breast cancer from using the synthetic progestins, and that's what he's referring to in that study.
Question from Tom Higgins. He says, our patients are feeling the scalpel initially. Suggestions for better pain relief?
Sure. I started answering that in the dialogue there. So a couple things, two things is that you really want to, the patient should only feel, in terms of pain, the initial stick, quote unquote, right, from your needle. You want to make sure that first use of the anesthetic is intradermal. I always tell my nurses or my nurse practitioners, like you're doing a PPD, just underneath the skin, and you should get a little wheal that forms. You should see it bubble up so you know the skin got anesthetized. The other thing you can do to speed that up is use some sodium bicarb, which increases, or I guess decreases, the onset time, makes it faster, the onset time of the lidocaine. Potential problem with the sodium bicarb is it's expensive in comparison. So I had one doc, and he's like, oh, I just use 2% lidocaine, that's it. And I anesthetize them, and I wait 15 minutes. I don't want to do that. I just use some sodium bicarb. It speeds it up, and you want to do a real nice intradermal so you see a wheal come up.
Great.
And the two things I see from a training perspective, sorry to follow up, is doctors sometimes they feel that initial stick and they feel the very end of the track. Those are the two mistakes or learning curves that you see commonly with insertions.
Dr. Jeff Farah, thank you very, very much for a great presentation today.
Thank you guys so much. I appreciate it.
Our next presenter is a healthcare synergist. His superpower is the ability to understand new advances in healthcare and make connections that really benefit people. And he's not just an astute observer, he's an active participant in many parts of the healthcare industry. As a speaker, he's in demand on platforms all over the world. I know I've traveled with him to some of the countries where he's spoken. He's written 11 books and authored countless seminars that are either delivered live or on video. And his newest book is called Feed Your Skin Right. It will be out in February. I can't wait to read it. And I know all of this because I have the privilege of working with him every day at Changewell Training Academy, which is our company. Dr. Mark Tager is who we're talking about here. And Mark is going to tell you about the vagus nerve, which is the body's superhighway to better health. And he'll explain why stimulating the vagus nerve in a particular way can help longtime migraine sufferers, how it can provide relief for troublesome conditions like GI motility disorders and reactive airway disease. And best of all, you'll learn about a unique device called Gammacore. It's the world's first non-invasive cervical vagus nerve stimulation system from electroCore. Dr. Mark Tager, take it away.
Thank you, Robert. Great. It's my pleasure to be here. Many of you might know me from my days as starting off with the Fraxel laser. And you know that I'm sort of really interested in how devices work. And I look for technology that is going to really transform the practice of healthcare. Many of you also know me as a communicator. And when I look at the human body, I think, how do we get these messages across to all the cells and the tissues and the organs of our body? Well, we've got chemicals and we have nerves. And as we learned in medical school, there is a nerve called the vagus nerve, the 10th cranial nerve, and it is the wanderer. And we've heard so much about that particular nerve. So here's what I'd like to get across today, and this will be a discussion. I'd like to review the role of the command and control center of the body, which is the autonomic nervous system powered by the vagus. I'm going to also talk a little bit about not just the autonomic nervous system part, but the decrease in systemic inflammation that we get when we stimulate the vagus nerve. We'll look a little bit at the history of the science and the mechanisms of a new way of stimulating the vagus. That's non-invasive cervical vagus nerve stimulation, called NVNS. We'll talk about a product called Gammacore, which just has me so excited as a great tool for patients today. We'll talk about the 7 on-label clinical indications and migraines and clusters. the emergency use authorization and COVID for lungs. We'll look at specifically, because we're kind of piggybacking with hormones, we'll look at menstrual migraines and the data on why GammaCore can be so great for that. Then we'll talk about some other applications in neurology. There's some exciting work being done in Parkinson's and PTSD, the acute treatment of stroke, and other conditions, particularly GI motility and reactive airway disease. But what I'd like to focus on first, and maybe this is last, but it's first, and that is this concept of multimorbidity and how it has its roots in something we're going to call vagal insufficiency. And then we'll talk a little bit about how to use this in your practice as well. So as a functionally trained physician, and I'm sure many of you are integrative functional, but you don't really have to be. This is what you see in your practice all day, this multimorbidity. We've got patients with migraines, but also GI motility disorders, HPA axis dysfunction, their cortisol is out of whack, immune dysfunction, insulin resistance, hormonal dysregulation. They have disruptions in their circadian rhythm, the lack of restorative sleep. There's a dysfunction in the gut, brain, skin communication. They suffer from dysbiosis, leaky gut, and poor detoxification. So with that list in mind, we probably only have 4 people on the planet that probably don't have multimorbidity. So let's just take a minute and look at the vagus. This is the command and control center. For the CNS, it lessens the perception of pain, nociception. It reduces something called cortical spreading depression, which is the wave of electrical depolarization that leads to headache. And it has other brain modulation effects, including effects on the lymphatic flow. We know in the heart, it reduces heart rate and blood pressure. Pulmonary, it dilates and increases bronchodilation. Hepatic, it helps with the regulation of gluconeogenesis. In the spleen, it's important to downregulate systemic inflammation. And GI, that nice, gentle peristalsis, this is a function of vagal tone, vagal innervation. So it will help with the increase in GI motility and secretions and satiation as well. So if we look at the vagus, and you may remember this from your days in training, it's a mixed nerve, but 80% of it is afferent sensory, and coming from both the jugular ganglia and the nodose ganglia. But then what's more important there are the fibers that come in this nerve. We got the large myelinated fibers, so those are the C fibers, and primarily and I'll come back to that in just a second, but the ones that we really impact are the small myelinated fibers, the B, that have a parasympathetic efferent effect, and the small unmyelinated A fibers that are afferent, mainly visceral. We don't really touch with the GammaCore the C. We have no effect on the fibers on the right side going down to the heart. In fact, we've got safety studies showing we have to, this very specialized wavelength and frequency, essentially frequency, we would need energy of 100 times more to affect the heart. So you can use this technology very safely without affecting the heart. But we're not the first, the GammaCore people are not the first to think about carotid stimulation. We know that early on in the 1880s that we could suppress seizures by manually massaging the carotid artery near the neck. And that's a very kind of crude vagal stimulation. In the 40s, we showed that we could have an anti-convulsant effect with an invasive device in dogs. And this was a physician called Dr. Cushing. And then we started to really ramp things up. So in the 1990s, late 1990s, the FDA approved an implanted, we call it IVNS device. It's wrapped around the carotid and a surgical procedure for refractory epilepsy. Fast forward to 2003, 2004, when the electrocore company was started. We began now to have IVNS approved for chronic treatment resistant depression. And in 2017, the first version of the GammaCore device was released. And it was released, it got FDA clearance for the acute treatment of episodic cluster headache. Went on to get clearance for migraines and for prevention of cluster headaches. And you'll see right now the device down in the right. I'll show that in action in just a little bit. So we have three ways we can stimulate the vagus nerve. The first is this surgical procedure in which we're essentially wrapping a electrode around the carotid artery. It's an expensive, invasive procedure. We also have these auricular kinds of things we put up by the ear, and they stimulate anywhere from 2 to 15, 16% of the vagal fibers. And then we have these cervical, non-invasive cervical vagus nerve stimulators. And you can think about this as a way to get to the superhighway that is the vagus through the neck. So what is GammaCore? Very simply, it is a non-invasive vagus nerve stimulator, NVNS. It is prescribed by you, but it is delivered at home by the patient, and it is ideal as a primary or complementary therapy. Now, the beauty of this is that it avoids many of the drug-like side effects. There's no injecting, there's no inhaling, there's no taking medicine all the time. You can use it with other medications as necessary, and it can be used for multiple attacks, and we'll talk more about that later. So these are the clearances. Now, the device is widely used in Europe. It has some EU indications where it is indicated for primary headache, airway reactivity, GI disorders, anxiety and depression, and epilepsy. And FYI, it is covered by the insurance in the UK as being cost-effective for cluster headaches. These are the clearances in the US, prevention and treatment of clusters, migraines, also in adolescents, treatment of hemicranium continuum and paroxysmal hemicranium. These are excruciating headaches on one side of the head. And it has also gotten emergency use authorization for adjunctive use in COVID breathing for the exacerbation of asthma. The device is being used extensively in the veterans system. There are over 5,000 veterans using this today. They do not pay for this device. The Department of Veterans Affairs, the DoD, believe that it has met all criteria for both safety and effectiveness and cost effectiveness. So the device is used and given to veterans with cluster headaches. Now, you may be wondering, why do I show you a picture of peanuts? I'm not personally a big peanut fan, but neither is Dr. Peter Stotz, who actually was the founder of electroCore. And Dr. Stotz is widely recognized for his work with pain. He's got over 450 peer-reviewed articles. He started the pain program at Hopkins and ran it for 10 years. But his son had reactive airway disease to peanuts, and in fact would have anaphylaxis. And Stotz at the time, Dr. Stotz, was president of the North American Migraine Society. And he said, well, wait a minute. We know that we can open up the airways. Could we, in fact, use this for prevention and or treatment of reactive airway disease? And so this was born, and they did a small animal study, then moved on to a human study. And in the human study, they show improvements in FEV1, forced expiratory volume, and also in decreasing the work of breathing. So this was very promising. But what was the most interesting about this study, and you'll see then the product was called AlphaCore. It was the blue line at the top. If you look at the bottom left, you'll see, did you experience any other benefits of treatment? Please describe. My headache went away. And this started really the birth of a company, the company of electroCore, and specifically for migraines. And migraines are a huge, huge problem in America, with 16 million Americans having this problem. So if you are in practice, you see patients with migraines. You may or may not be asking about that, but these patients have them. And over and over, this device, the company itself has done some great studies, big studies, well-designed studies to get their FDA clearances. They've done 7 RCTs. They've done investigator-initiated trials. And there are just in headache alone, over 70 papers that look at mechanisms of action and clinical use. So this is a device with some very, very strong research behind it. And for those of you who are interested, I'm not going to go into any depth. We can certainly give you more of the papers. There are well-published studies, large studies that have formed the basis of the FDA clearances. Just highlights in migraine, the clinical studies show that patients get fast relief. They can become pain-free. It tends to be long-lasting pain relief. They get a reduction in migraine days, and there are really no adverse events. Occasional little irritation of the skin in people who didn't use enough gel. Very interestingly, we had a pharmacist, a licensed pharmacist can prescribe this. This is a prescribed treatment. You have to be a licensed healthcare practitioner. He had a patient come in with a migraine. He took the device out, set her on the side, had her use the device, and the migraine went away. So the cluster headaches, you probably will never see, most of you will never see a patient with cluster headaches. It is the worst pain known to mankind. It is suicide. The number one link to it is suicide. This is excruciating pain. And this device provided fast relief. It was reliable. It reduced the duration and the severity. And this is why, where there is no other treatment that works for this, this is why governments in the UK and our veterans hospitals are prescribing this. So how does it work? What does it do? Let's look at this 4 quadrants. We'll go around from the cortical spreading. So it reduces the spread of this depression, which is the depolarization that causes headaches. This results in a decreased perception of pain. But the 2 pieces that I'd like to look at here, the autonomic nervous system function and neurotransmitter modulation. So what we're doing here is we are essentially boosting up the parasympathetic system, and we certainly see that in the GI system. We see it in the brain, but in the GI system. We are also dramatically impacting neurotransmitters. And this is important because when we talk about hormones, we are again talking about the chemical transmission to nerves in the body. So that we're able to get this balance. We're able to take down excitatory neurotransmitters like glutamate and upregulate serotonin and acetylcholine. And this can basically result in fewer attacks, acute pain relief, resolution of attacks, and the relief of the sort of parasympathetic nervous systems that we see. Very often, you'll see people with migraines, and they'll also have eye weeping, or they become a little short of breath, and that's because of the parasympathetic, the sympathetic dominance that they have. Now, it's interesting because if you think about a drug goes down a single path. We want to stay on target, and we never want to go off target. So it is a very narrow pathway. When we think about vagal stimulation, we're really talking about broadly affecting neurotransmitters, the autonomic nervous system, the perception of pain, depolarization. So we're getting really, in a lot of ways, more shots on goal. Okay, this is being explored. Electrical medicine is being explored throughout the world, both the afferent and efferent pathways. You can just see all the different conditions here where there's research being done in the top universities in the world on things such as Parkinson's, opiate use disorder, traumatic TBI, acute treatment of stroke, PTSD. On the efferent side, gastric pain, GI motility, NASH, some of the inflammatory syndromes, etc. I want to segue and do go over a little bit of the research on migraines because 1 in 5 women have migraines. And the company did a study that looked at the use of this device for the prevention of menstrual and menstrually related migraines. What do I mean by menstrually related migraines? These are migraines that come perhaps in the middle of a cycle or not exactly timed to the menses. So they took a large group of women for 12 weeks, did an observational study, baseline, essentially how many headaches did they get, when did they get them, and then they took and treated them. This was just open label. There was no sham treatment. And what they found was statistically significant. So if we look at the number of menstrual migraines or related migraine days per month, the drop was from 7.2 to 4.7, which was significant. But you really want to know, you want to make sure that something works. And so what is a success? How do you define success? Well, a success in headaches is having greater than 50% reduction in the mean number of menstrual migraines or related migraines from baseline. And here we had roughly 40% had greater than a 50% reduction. So this attests to the fact that the treatment is effective. And looking at this another way, looking at analgesic use, you can see that the analgesic use dropped from a frequency of 9 down to 5.5. And again, that was statistically significant as well. So the conclusions there, because we are talking so much about hormones, is that it is an effective treatment. One of the few little things, we tend not to see aura in menstrual migraines, and we don't know why that is. And another thing that we've learned is all it really takes is a 10 microgram drop in estrogen levels to trigger a migraine. So this is this can be adjunctive to your hormone replacement therapy. It can be early on as an option for your patients as well. So let me just briefly cover some additional potential indications, what we've got some research on. Fascinating work done on Parkinson's, in which we've been able to get improvements, see improvement in gait. Why do Parkinson patients die? They die because they fall down and break their hip. Why do they fall down and break their hip? They shuffle along, and then if they have to turn their body, this is when they fall and break. So anything that you can do to improve gait in Parkinson's is important. We've also noted that because of this multimorbidity, the fact that the vagus nerve is running through the body and touching just about every of the major organs, headache isn't just a headache, it is a headache plus. So we see this certainly in GI pain and motility. We know that there's a gut-brain axis. We talk about this all the time. But 90% of the fibers in the vagus nerve carry information from the gut to the brain and transmitting information about pain, inflammation, intestinal barrier integrity, and microbiome. And although we like to say a happy gut, happy brain, it's a great phrase, that our gut bacteria are making serotonin and all these other neurotransmitters, there's no evidence that any of that from the gut crosses the blood-brain barrier. The effect of the gut microbiome created neurotransmitters is via the vagus nerve. So we see that there's certainly a role of intestinal permeability in migraines. We see one of them being LPS, the endotoxins on bacteria getting in and causing inflammation. Other things can do that as well. But we see, and the gut microbiome contributing to that. So we see here in this pain syndrome, your patient comes to you with a migraine, hormones and regulatory peptides. We've got the neurotransmitters going on. We've got cytokines. We've got all of these messages and the contributions of the gut microbiome all going to contribute information to that afferent vagus nerve that's going to result in pain. Some good studies on reduction of GI pain. Another one that makes an enormous amount of sense is gastroparesis, in which we have to begin to restore normal motility to the GI tract. We want to get that nice coordinated wave of motility going. So we've got some other major studies going on that as well. Now, the last thing I'd like to touch on is a mechanism that all of you, I'm sure, are familiar with. So a headache is not just a headache. It is a headache that is also driven by systemic inflammation. So how do we control inflammation? Sure, we all talk about cytokines, and we talk, one way is through the JAK inhibitors. We talk about the control via the neurotransmitters. But this is all done through the autonomic nervous system. This is the driver of inflammation. So now how do we know that if we were to affect the autonomic nervous system through vagal stimulation, that we would do anything? So this was interesting, and this has how Gammacore got its emergency use authorization. So the mechanism of COVID, certainly early on the Delta and the first version, the Delta version, we saw the cytokine storm. We saw damage to the lungs, and this was related to smooth muscle contraction and constriction and inflammation, the cytokine storm. So what they did was they used the device with and measured CRP, and you saw a very dramatic and significant drop in CRP. There was a significant drop in TNF alpha. In the bioactive reduced form of glutathione, which is a very important protective antioxidant. And also, interestingly enough, improvements in BDNF. So we've got the brain biomarkers as well. This is what I pointed to a little earlier about the gait in Parkinson being important. And just last week, the FDA agreed to provide breakthrough treatment diagnosis designation for Gammacore use in PTSD, looking at a study that was done in Atlanta that showed a 31% reduction in the symptomology around PTSD. And this occurred via both the nervous system, but also the change in blocking of some of the inflammatory markers. But it also blocked these flashbacks, that triggered anxiety and depression. So I thought that was fascinating as well. So there's a world of electric cures out there. This is the safety information. This is a very, very safe device. It is really only contraindicated. The major one is if they've got a metallic device, a stent, bone plate, bone screw in or near the neck. You wouldn't use it at the same time you use TENS. As with many things, we just don't know. We have not evaluated safety and efficacy. And folks with congenital heart problems and carotid atherosclerosis, and those who've had cervical vagotomy, pediatric patients, pregnant women, we just haven't evaluated that yet. So how does it work? Let me sort of kind of grab mine. And so you get comes as a nice little kit like this. You have to charge it every couple of months. And you've got this handheld stimulator. We instruct the patient to find the vagus nerve to prepare for it. They turn the device on, put on a little gel. There's some a special gel that comes with the device. They put it up against their neck. They press the buttons until the end point, I'm not going to do it right now, the end point becomes a little tug on the lip. And so that is the endpoint. That means you've activated the platysma and you have reached the vagus. It lies about 1.6 centimeters down. So you are getting that activation, and you hold that for 2 minutes. We call that one stimulation. You do it, repeat it, put the gel on, put it up against the neck. It's not painful. You'll feel a little tingling sensation. It's not painful at all. You'll get a little bit of a lip pull. And the second one, that is what makes a treatment. Treatment are 2 stimulations. And usually what you're doing is you are doing this morning and evening, and hopefully at noon as well for the more serious things. So the great thing about this is that the company has many resources for you. First of all, they have a one-on-one training. So when you get the box, you open it up, the patient goes ahead and calls this phone number. They get a patient experience individual who will walk them through setting it up, finding their carotid and their vagus, placing the device properly, doing a stimulation properly. Of course, you can do that in your office as well, but you can do it both. And there's some great demonstration videos on the website. There's some quick start treatment guides. So that's okay, right on time. Good thing I grew up in New York. I can talk fast. So I'd be delighted to take some questions a little bit later as well.
Yeah, go ahead. If you have questions, go ahead and put those in the chat right now, and we'll get to those in just a second. You know what it is, you know what it does. And Mark, like all of your presentations, without a day of medical school, I feel like I learned a lot. And not only did I learn a lot, but I actually understand a lot, which is great. Now, if you're a practitioner, you may be wondering, what does this cost? How do I get one? Well, because you're here on this webinar today, and if you are a licensed healthcare practitioner, you can actually get one for free. You heard me right, free. You can try it out on yourself. You can use it with patients. You can experience the results firsthand. Now, here's the catch. Again, it's for licensed healthcare practitioners only, and there are only 10 units available. So how do you get one? Well, the person who's keeping count is Lisa Martin. She is electroCore's Director of Customer Experience, and you should be seeing on your screen right now, I see it on my screen, how to get in touch with her. You can email her, lisa.martin@electrocore.com, or you can call her at 973-355-6694. When you do, be sure to mention the webinar offer. She will know exactly what it is that you are talking about. So go ahead and grab your phone and take a picture of the screen so you get that, and we will send it to you via email. So Mark, a question from Teresa. She says, can we use Gammacore in the US for anxiety and depression now?
You know, it is, this is a licensed, this is an FDA cleared device. It has indications and it has promise. Teresa, nice to see you. So there is no contraindication to you using it. We do not have a study to say that. It is interesting, however, that it was effective in this PTSD population. So there is good rationale for using it with anxiety and depression, although the company has not done a study on that, nor is it directly cleared for that.
Okay, so I have a question if I can. You talked about the endpoint being a little tug on the lip.
Yeah.
What does it feel like when you're?
Oh, it's a little tingle. It's not painful. It's a little tingling sensation. And what you do is when you put it up against your neck, you are. I don't have any gel on now, so I'm probably not going to do this for real. But what you do is you press a little button until you feel a little tingle. And then you'll get to a point where you get a little tug, and that's it. And you stay there for the 2-minute period. And that constitutes a stimulation. So, you know, for me, what's the most fascinating this, I've been a student of the vagus nerve my entire career. Tai Chi, acupuncture, yoga, meditation, breathing work, heart rate variability training. And it's all great, but it all takes a lot of time and discipline. And this is just such a powerful way to get that impact. And personally, I don't have too many conditions. I don't have anything, knock on wood. But I do this when I need to feel calm and collected and cool. And it's a great way to, you sort of get this peaceful, tranquil feeling afterwards.
Cool. Great. Mark, thank you so much. Great presentation today. Now, if you're going to invest the time and effort to bring new solutions into your practice, it kind of makes sense to think about how to bring those new solutions directly to patients, both your current patients and new patients, how to get them to understand that in addition to what you've always offered, you have these new ways that can help them feel better. And that's why we're really delighted to welcome our next presenter. Friends and clients of his say that he is a genuine resource who operates at the leading edge of where technology and media intersect. Today, he is the vice president of strategy at a fast-growing digital marketing company, which has been repeatedly recognized by Inc. magazine. And what's really, I think the best news of all, they specialize in helping healthcare practitioners. We can't think of anyone better to show us how to take new practice offerings and turn them into new practice revenue. Please welcome our next guest, the vice president of strategy for MyAdvice, Chad Erickson. Take it away, Chad.
Robert, thank you. I really appreciate that. And kudos to everybody who's on here. 2 hours is a long time, and we want to keep things moving, keep it fresh. But I really applaud you for taking time on a Friday afternoon to educate yourself, to find ways to make your practice even better. And I'm confident that you're going to find some great information in my presentation today to help you as well. So again, thank you for listening, and let's get started. So I want to talk about what we call the pyramid of success. The pyramid of success is essentially 22 years of research and innovation that has gone into making sure that we're helping small practices like yours to succeed in today's world and make that so that it's also affordable. When you think about your digital marketing and the type of patient that you want to attract, you need to have a proven strategy and a proven system that's going to make your life easier, more complicated. And I'm going to take you through each of these elements today as we go through this and why they matter. The first one that we're going to talk about is going to be websites, but I want to point out something very, very quickly, and that is that it's really, really important on the order of the stages. And I'll give you an example, kind of backing up just a little bit. I remember we were working with somebody before, and they had paid search as part of their process, but their website was terrible. And so they were spending a lot of money. People were going to the website and then not acting. And they were like, before they came over to us, like, our PPC doesn't work. And we're like, well, why? And you dig into it, like, well, it's because once they clicked on your ad and they look at your site, it was an incongruent message. You actually need to give them a reason why they want to stick around, and it didn't look the same. And they're like, oh, and we fixed that, got the order done properly, and all of a sudden they saw their conversion rate shoot through the roof. So again, the order of everything really, really matters. And this is something that we have been able to prove with thousands of clients over the last 20 plus years. And so I'm excited to share these ideas with you today. So again, your website. And why did we start with the website? In fact, I had someone recently ask, does your website even matter anymore? And the answer is absolutely. And we'll talk about why that is. So why do we focus here? Well, your website is still the nucleus of everything that you do. It is the center point. It is the first impression that people get about who you are and what matters. And it really, really stands out. Your website can be a make or break element. It has to be, significant in what you're doing, why you're doing it, and are you reaching the right audience? I had this is an example of a website, and is your website meeting your audience needs? I had a client, well, he's a client now, but when I first met him, we met at a conference and we got talking, and I asked him, what are you doing with all your marketing? And he told me, this, that, and the other. And he said, well, you know what, Chad, I'm the best injector in town. I get better results than anybody else. My reps tell me that I'm the number one volume person. I said, great. And it actually didn't bother me that he was saying he was the best. I actually prefer that than someone saying, well, I'm okay, or I'm mediocre, right? And I said, well, what's your biggest challenge? He said, I still have a lot of openings on my schedule, and I get a lot of looky-loos, if you will, but they don't take action. I said, well, let's take a look at what's going on. So we pulled up his website, and within a few seconds, I said, well, I can see what your problem is. I'm like, your website's so outdated that people hear about you from their friends. They see your reputation on social media, your reputation scores, and they go to your website, and it doesn't match. Your website says you're mediocre, in fact. And he was like, oh my gosh, you're the first person to actually tell me the truth. And it was like eye-opening for him, right, to recognize that there was a real disconnect on the message and type of patient he was trying to acquire, the things he was offering, and what was really coming out. So anyway, we got that corrected. So ask yourself, how does my website look? And as you're asking this, make sure that you're thinking about it not just on a desktop, but in particular on a phone. This is the first place most of your people are going to go. And that first impression is critical. You want to make sure that it looks amazing. So be critical of your own, everything else you're doing, and be critical of yourself. So look at that and take a look. So again, when that website is in order, everything else really falls into line. That's why it's foundational. It's why it's the first element that we look at on the pyramid of success. The second one is really your local search. And what do I mean by this? Well, this really applies to your Google My Business. It also can apply to Yahoo, Bing. It can also be Yelp, Angie's List, White Pages, all these other sites, and all of them give an indicator back to Google on whether or not you care about your focus. But the reality is that millions and millions of people are searching on this, and it's really important. It's actually a major indicator to Google on how to rank you organically. They call it your NAP score, your NAP ranking, NAP, which is your name, your address, and your phone number. And in a very practical sense, let me tell you how this works or doesn't work, depending on whether or not you're paying attention to it. I was with one of our sales reps. We were in Thousand Oaks, California, and we had an appointment set up, and we typed in the address in Google Maps, took us right to the building. We got to the lobby, and we had the suite number, but wanted to validate it quickly on the board that's in the lobby. And we couldn't find him. And we thought, well, this is weird. And so we thought, well, we'll go up anyway to what's listed on the address here. And we got there, and it was not the same practice. And so we quickly called them. We're like, hey, we're at the office, but we can't find you guys. And they're like, oh yeah, we moved from there like 6 months ago. And we're like, wow, this is crazy. And we went to their reviews, and the reviews over the past 6 months were dozens and dozens of people who were frustrated and actually were lambasting them because they had driven to the wrong spot and then had to go 20 minutes across town to the new location. And all it would have taken is a little bit of time and effort to correct that with their name, their address, and their phone number, and it would have alleviated so many issues. So it's important to take a look and look at your own details. And there's ways to do this. We actually have some software that'll run a scan for you. If you're interested in that, I can, at the end, I'll provide my information and I can give you that link. There's no cost to you, but it's important to make sure your information is coming up accurately on all of these sites, especially in the medical field. Health grades, rate MDs, vitals, of course, Google at the top of that list. You want to make sure that you're coming up accurately. And the reality is you don't have time to do that, which is why within our system, the Pyramid of Success, we're actually taking everything I'm talking about, and we've created a way to do this for you and to save you time and effort. And it can all be managed in one central software package for you. So again, very, very easy to do that. So again, we look at the website, we look at your local search, and the next most important thing is online reputation, making sure that your reputation is showing up the way that it wants. And listen, if we had time and I could see everybody, I would ask you, have you ever received a negative review? And I virtually guarantee that every one of you would have your hand up like, yes. And you could tell me exactly why, and it probably was some crazy patient. In fact, it's probably somebody that you knew was crazy at the beginning, and your gut said, I should pass on them. And they turned out to be as crazy as you thought they were going to be. I hear stories like this every single day. But why do we focus here? It's because people trust online reviews. And you think about, we just came out of a holiday, shopping season. And if you were like me, you were also looking at the reviews on Amazon and other places and making sure, is this a trustworthy place? And if I saw the reviews, I didn't have to trust all the 5 stars. And I even looked at some of the ones and how recent was it, and if that person was crazy. And listen, people can spell crazy from a mile away, or someone that has an axe to grind, right? But the reality is that consumers will trust what they read. And I want you to pay very close attention to this graph on the right. The first thing that they do, once they read your reviews, is then they go to your website. So we talked about having this all in order, and the order is so important. So again, that website has to be foundational. If there's a disconnect and they've gone to your reviews and people are seeing 4 and 5 star reviews, let's say it's a 4.8 aggregate review, you go to your website and your website is outdated, has broken images, doesn't match what your message is today. Maybe as an integrative practice, you've added a lot of new modalities, but you're still showing something completely different and haven't really updated. There's a disconnect, right? Your messaging doesn't work anymore. So you need to make sure that website foundationally is there and working. So with reviews, what do you really have to pay attention to? Well, you need to have a system in place. Do you have a way that monitors and notifies you of any good or bad review online and automatically will alert you? If you don't, you need to have that system in place. It's one of the things that we offer. Secondly, is you have an easy way to respond to those when they happen, but maybe more importantly, is you have an easy way to request them via text and email when your patients are in the office or at the end of the day. We have multiple ways that can be done via text, email, but again, all within the same software platform, which makes it super easy for every member of your staff to do it. And if you have multiple locations, no problem. We do that as well. If you want to create gamification within your practice so that the members of your staff, if they're held to a standard that they need to get so many reviews each month and request those, you can do that. We actually do that at our own practice. And our customer success reps are incentivized to make sure they're asking their clients and customers who they are working with every single day to leave reviews. And we reward our people for doing that. So again, there's a lot of ways it can be done, but you need to have this system in place. And this is something we can absolutely help with if you don't. So the fourth part of this, and this really kind of rounds out what we call our power suite. It's your signature website. It's going to be your local power, your review power, and now your social power with your social media presence. Social media, as you know, has become critical to every practice today. It's not going anywhere, and it's a major part of your brand. Your patients expect you to be active on social media and posting, on a regular basis. And so what we find with a lot of practices is they're like, I don't have time to do this. Maybe I can do once a week. But Google wants to see consistency. So one of the things we do at MyAdvice is we post for our clients 4 times a week on Facebook and Instagram. And we want our clients to then augment that with what they're doing. The other part that's really, really important is that we have created a system around it. So we have our software, and our software allows you to schedule out all of your posts as far out as you would like. So if you know, hey, next month is so-and-so's work anniversary, or it's a birthday, or we're going to this conference, you can start scheduling out all of your posts during that time. So again, alleviating the need of like, oh my gosh, it's Friday, we didn't post anything this week. Hey, it was something cool, we need to hurry and do something. You can each month, each week, have a strategy in place and make your life easier. We also have a massive content library that our clients can go and grab content from as they're building out their own calendar on top of what we're doing for them. So again, our job is to make your life easier, to allow you to not only increase the top of your sales funnel with new patients, but also to keep them coming back to you. And again, we want to make sure that you're successful with every part of that. If you only have these parts of the pyramid of success in place, you would have a very successful practice. but we want to make sure that you're not frustrated, that it's easy to do. But again, thinking about those bottom four, right? It's your website, it's your local presence with your Google Maps and all the other local search engines, it's your reputation management and your social media. That's a very solid base to what you're doing. Once that's in place and you're doing a great job with that, that's when we suggest you add on traditional what's called search engine optimization. Now, I will say every one of those elements actually plays a critical role in SEO today, but our practices who really want to boost things and actually it's like dumping fire on what they're already doing, this is where they're going to add more and more patience into what they're doing, is with the SEO. So we focus here because it's all about perception. How are you showing up on page one of the search results, particularly on Google? Because we know for a fact that more clicks on Google is going to equal more conversions and more patients. And that's good news for you. So knowing that 75% of people searching don't make it past page one, that's where you want to be, is on page one. So asking yourself, do you have a strategy that's going to take your keywords, your phrases, and build on your content? Do you know how to work on your alt tags, your meta descriptions? Do you have a content strategy for growing everything you're doing? And more importantly is, do you or members of your staff have the time or expertise to do those and make those adjustments? If not, that's why you want to hire a company like MyAdvice to do that heavy lifting for you so that you can focus on your new patients and existing clients. Now, the last part of this, again, once everything is stable, is making sure that you have a great paid search or pay-per-click campaign. Now, this can be done on Google or Instagram or Facebook or even TikTok and other places. But this is a great way to accelerate what you are doing. So we focus here because the ROI on this can be massive when done properly. And it also can be a complete money loss when not done properly. And let me explain what I mean by that. I have a practice in New York that spends around $40,000 a month on Google AdWords. Some of you are probably like, that's way too much. And I want you to rephrase the way that you're thinking about expenses when it comes to marketing. It's not too much if, like this practice, they're making $500,000 a month on laser hair removal, one procedure. Now, it took them a while to get there, and it took them a while to figure out what the right spend was. They've realized that if they spend $50,000 a month, it doesn't net them any more than the $40,000. But if they drop down to around $30,000, it absolutely declines. So their sweet spot every single month is $40,000. And for them, that works. Now, where I'm at in the Salt Lake City area, I couldn't spend $40,000 a month on that single procedure if I wanted to. I don't have enough eyeballs. So every area, every procedure or service you offer, it's going to vary depending where you're at. So you really have to have a company that knows what they're doing, knows how to evaluate that, and knows how to make sure that you're spending it properly. And that's why I say you can just throw stuff out there and you're going to lose a lot. Also, you want to make sure that you've got a good strategy for responding to the leads that come in, because it is going to absolutely increase your lead flow. We had a practice of ours who very well established practice, and they have a large staff. They wanted to increase their lead flow. So we turned on a campaign, and within 2 months, we had to turn it off. And the reason was they couldn't respond to the volume of leads coming in. And it was crazy because we sent them about 150 leads. 75 of them were high quality, people that wanted a facelift procedure, which is a $20,000 surgical procedure. And the staff just didn't respond. When you listen to the phone call recordings and saw the emails, they just never got back. And the doctor was like, Chad, we're not prepared for this. Can you turn it off? I'm like, absolutely. Just you get things in order. So you need to have a process in place to make sure that you're ready for that type of volume that's going to come in for your area. So does pay-per-click work? Absolutely. But again, it only is going to work when everything else is matching, so that when people are clicking on that, they feel like, wow, this is a great group, a great practice that knows what they're doing, and it's a place where I'm willing to go spend my money. And just like Jeff was talking about earlier, when you get the right patient in and you have the right thing that's helping them, they're going to come back over and over and over again because you are making their life better. So that's what we're trying to do as well. So you think about this, and if you're running a pay-per-click campaign right now, there's a lot of questions to ask. Are you seeing your competitors' ads when you type in your own name? How are you going to measure your success? What's your budget going to be? So these are all things that are part of the evaluation process and what we're doing. So again, reviewing real quick as we're kind of wrapping up here, this is the pyramid of success, and the order matters. You want to make sure you have an amazing website that has the right messaging. You want to make sure your local SEO, your Google My Business listing, your map listing, your name, address, and phone number are accurate. You want to make sure that your reputation looks good, and that you have a strategy for building on that every single month and adding more and more high quality reviews, but also has a place for you that whether it's a good or bad review, you have a way to respond to that. And by the way, if you've got a bad review that you've got questions on and you'd like some help with, I'll share my information with you, and I've got some good strategies around that and how to respond to those. Your social media presence is absolutely critical, but having a system is going to make your life easier. That's why we post for most of our clients, and that's why we make it easier for you by giving you that scheduling calendar within the same software package. So everything is in one location and easy for you. And then when that's in place, if you're like, hey, I'm ready to really dump the fuel on this, and I want to increase the number of leads at the top of my funnel and new patients coming in, and the right type of patients, right? SEO and pay-per-click absolutely become a critical part of your overall marketing strategy. And we can help you with that. So here's my information. It's chad.erickson@myadvice.com. Happy to help you in any way I can. If you would like just an evaluation on what you're currently doing, your website, let me know. We can do that. All right. Thank you so much for your time again today.
Now, Chad, I'm guessing with my great powers of mental perception that a company like yours might have an attractive offer for people who are inspired by what you heard. Do you?
We absolutely do. So one of the things that we've put together for this group is we have an offer that is going to be, it's actually slightly variable. You're going to love this though. It's a 20 to 44% discount. So I outlined our pyramid of success. So as you add additional products on that, you can actually get up to anywhere, at the social power level. As soon as you get to social media, you can actually have a 44% discount on what you're offering. So again, it's a huge discount that we're making available to everyone who took the time to be here and stayed in contact with us today. So thank you again for your time and for being here. We're happy to offer that to you. Thank you so much. Any
That's
questions
great.
We've got?
Now, I have a question for you, and I want to get to that in just a second, but I also want to put on the screen another offer, and this is from Changewell Training Academy, which is the company that I have with Dr. Mark Tager, and it's in cooperation with MyAdvice. On May 20th, 21st, and 22nd, we're offering a live in-person weekend workshop. Dr. Tager and I are going to lead this in person. It's the Present Well Presentation Skills Workshop for Advanced Healthcare Professionals. And we're doing it in Park City, Utah at MyAdvice. Why? Well, because that will enable us to use their incredible facility. And also it will enable you to attend and get hands-on advice on your website from the folks at MyAdvice. And I put a little tile on the screen. We've got a web page that we're building. It's not done yet, but if you want to take a look at it and see if this is for you, that would be great. Now, Chad, I do have a question. And yes, when you're talking about the NAP score, name, address, and phone number, let me give you an example. Let's say I'm in practice and I've got 3 directory listings. One is Robert J. Hughes, MD.
Yep.
Same street address, same phone number. The next one is Dr. Robert Hughes, same suite number, same street address, etc. And the third one is Hughes Medical Clinic, same street, same suite number. How does Google look at these slightly different directory entries?
So Google does not like those when there's incongruencies like that. Now, what you're looking for is it's not uncommon that within the same address, you may have 2 different businesses. So there's ways around that, right? You want to have at least two of the fields matching up. But if you, ideally, it would be great to have them all be separate. So for example, or to really want, if we can have the name be the exact same, if it's the same business, we absolutely want the name to be 100% the same. And we want the address to be the same. We don't want to have the address to be 100 Elm Street, ST period versus STREET, spelled out. We want to make sure that's consistent. So Robert, if they're different businesses, that's one thing. And there are ways around that. We have to let Google know, hey, same address, here we go. In those instances, we should have a different phone number. And that's one of the things we teach our practices is make sure that two of the three are unique entries for Google.
Yeah, that just, when I discovered that with some of the clients we work with, it just blew me away. Just a simple little thing like Robert J. Hughes, MD, is not the same person as Dr. Robert Hughes as far as Google is concerned. Exactly.
They treat it differently. And so they want to see consistency. Right. It's a major indicator to them. I mean, we kind of break things down into SEO 101 and advanced SEO. And again, foundationally, that part of your NAP score is a critical piece that before you do anything else, that has to be lined up. That's why we put it right with the website.
Great
so question.
I don't see any questions for you, but I do see a couple of looks like customer testimonials, people who are working with you and are loving the experience. So congratulations on that. That's great.
That's wonderful. Thank you, everyone. We appreciate it. So,
right. Okay. So we are right at the dot of 2:00. We started precisely on time. Let's not screw it up. We're going to end precisely on time out of respect for you and your time. Thank you so much. Look for the replay. And when we do the replay, it's going to take a little longer to get that out because I'm going to go back and edit that glitchy video and sort of straighten that up so that the people who are watching the replay don't have to deal with that. Again, thanks to our presenters and ladies and gentlemen who attended. Thank you so much for you. Have a great afternoon and a great weekend. Bye-bye.
Thanks, everyone. Bye-bye.